Thank you.
Everybody see that?
Yes, we can. Thank you.
Okay, so just a plug, because Cheryl, as much as I like babies, I also love cases. And I really am excited that Cheryl said she might have a case to present. This presentation was designed because of my love of just talking about cases, and I threw together some common cases I've seen over the years, this with a focus on some psychopharm. This one is a little bit more complex, so we'll talk about psychopharm, but I also wanted to really talk about sort of managing kind of risk assessments and assessing suicidal ideations. That's become a huge issue within the world and a huge need. And one of the things I will say, I think from the educational side of things, there's a balance between making sure someone is safe, but also recommending the appropriate level of care. And as a educator historically, I think the biggest caution as we proceed in cases like this with a patient that presents with some suicidal ideations is that's helpful information, but that should lead you to what's the next step. I think one of the things I have seen work very poorly for patient care is that if you hear suicidal ideation, someone is rushing to send someone to the hospital or the emergency room, and that is not the appropriate order of operations, because not all children that have suicidal ideations, not all adults that have suicidal ideations need inpatient level of care. It is a symptom that needs further assessed. And that assessment includes an understanding of the severity and risk related to their thoughts about suicide and what level of care you can meet their needs to modify those risks to offer them hope and treatment. I've seen a lot of children hospitalized that really didn't need hospitalized, and sometimes the outcomes have been worse. And then they often don't want to share their symptoms and feelings with people for fear that they'll be hospitalized again because it was not helpful. And some people report even that inpatient hospitalization worsened them. And so it is really critical to make sure that you pause. And sometimes I think in the early stages of this, it's almost a panic response that providers will have on themselves. Oh my gosh, what do I do? I need to keep this person safe. And so as we launch into this case, my hope is to step back, keep asking questions, and be therapeutically supportive. That's what really helps people recover and have hope and safety, is to feel connected. And so although we're going to talk about this case bigger, my largest message with this case is to really not hear suicidal ideations and run away and start a hospital referral, but really to pause, understand the risks, and go deeper with the questions, as well as thinking about pharmacology and therapeutic interventions that could help. And so this is an incredibly common case. I'm sure many of you have heard this, but I'm going to walk through sort of what approach I might use. So this is a 14-year-old female. Let's see. It was a 14-year-old female that had no prior psychiatric history. She had said something at school regarding suicidal ideations from a social media account, not given a lot of details about it. She reported to some depression and anxiety issues and had been being bullied at school. She admitted to suicidal ideations, but no one had ever asked her about intent or means, or did a risk assessment, or even asked her details about those thoughts. And she actually is sent to the emergency room, but her parents are there with her. They're incredibly supportive, and they are miserable and just want to take her home for outpatient treatment. She does meet DSM-5 criteria for major depressive disorder. And the question is, well, what level of care does she need? What is the extent of this suicide risk, and how can we be helpful to her? And so some of the questions that kind of come up, can she safely be discharged home? What is her risk? Is this a low risk, a high risk, a severe risk? What type of follow-up does she need? Like, how often does she need to be seen? What other safety measures can we do to make her feel supported? And is there a medicine or other referrals that can help treat her depression, improve her mood, or address issues with regards to bullying? So when we talk about this concept of risk assessment, I know Colleen has shared comments about risk assessment can be translatable to many different things, right? It could be risk assessment for reoffending. It can be reassessment for aggression. Risk assessment is just a clinical gauge. It encompasses past behaviors and known risks but it also includes protective factors and understanding. And it is a clinical judgment and risk assessment. And this is the most important part. Risk assessment is time dependent. If I say your risk assessment today at this moment is low, it could be high tomorrow, and that negates everything we just talked about. And so it is a time-dependent assessment of where someone is at that moment in time. Risk assessments, honestly, I've seen them change within an hour. I've had people come in incredibly depressed, hopeless, feeling like they have no one in the world. People then hear the support of their family and loved ones, and they immediately don't feel alone and feel better and have hope. And that risk may immediately change that fast. It may not change at all. Some people live with chronically high risk factors that will never go beyond moderate to severe because of past attempts. And so risk assessment is a time-dependent, event-dependent sort of assessment. And so you must reevaluate it with every new piece of information or new event, because it really is fluid, not static in any way. So one of the first things is when someone tells you they're suicidal, don't freak out. Acknowledge that this is hard to talk about. Thanks for letting me know. Can I ask you some more questions about that? Because you want to know how often have you been feeling this way? How close have you gotten in acting on those thoughts? Have you acted on those thoughts? Is this something that kind of comes out of the blue, or has this been a daily thing? How many years has this been going on? How close have you gotten? Sometimes someone that has, I'll give you an example. Sometimes this person had no risks, never had depression, never. And I asked that question, how close did you get to acting? Well, that's a very different answer when they said they were playing Russian roulette just an hour ago when they had no other risk factors. Very, very different answer than, yeah, I thought about it, but I would never do that. I love my family so much. What keeps you from acting on those thoughts if they've never attempted? You can learn about some of the protective factors. You want to know about if they have a plan. Have you thought about what you might want to do? How close have you gotten to acting? Sometimes I ask people to sort of rate that. 10 means I think I might really do it if I left here. 1 would mean I really didn't. Maybe about a 2. That tells you kind of where they are with how intense they may be. You can ask if they've had past attempts. Have you ever tried to kill yourself? And you have to use the word kill or die. Just saying suicide means a lot of different things, and that can be quite different from self-injury. The other thing that brings a lot of children and patients to the assessment is chronic self-injury. Now, chronic self-injury is a risk factor for suicide, because if you're going to hurt yourself and you've already been hurting yourself not with non-lethal intent, it makes you more likely to have lethal intent, but you still have to reassess the behavior. There are many people that cut as just functional coping. I'll have people tell me that they're cutting or harming to feel something, or to not feel numb, or because it gives them a sense of control of their pain and their feelings. That again is still a risk, but it's a different risk than saying, I am trying to kill myself with that behavior. And self-injury is beyond just cutting. It can be things like burning, hair pulling, things like that as well. So you want to be as open-ended in how you ask the questions to get the information. You want to understand their stressors. What things make these thoughts worse? Do you feel sad? Do you feel depressed? Do you get anxious? How good are you controlling your urges? Do you feel sometimes that you have problems with impulse control, or that you're like 0 to 60 with how fast you can pause and stop it? Do you feel hopeless? Hopeless is a really severe risk factor when you have severe hopelessness for not, and we talk about that future forward thinking. If they do have future forward things, like, I have suicidal thoughts, but I have all these other things I'm looking forward to, and I could, that would be a positive factor. Irritability, substance use, especially if acute intoxication and withdrawal, can be a higher risk. And other stressors that may be going on, relationship stressors, school stressors, work stressors, new events can often trigger risks from chronic to acute. And then you want to know what their supports are. And it's just as important to ask, well, what are your reasons for living? Can you imagine feeling better? What would that look like? Who in your life do you trust, and who supports you? Can we let them know what's going on and be helpful to you? And so with kids, you may have some more support and supervision built in than you might even have with adults. And so there is an important interviewing that may need to happen from the parent and the guardian. Some parents are incredibly supportive, will do anything for their kids, and their kids view it that way. And sometimes the kid just needs a little help telling the parent they need more support or help because they're embarrassed or they're afraid. And sometimes it's a therapeutic intervention of helping them talk to each other to get that support. Some parents are not supportive and incredibly invalidating, and sometimes will be shameful of the child. So it is helpful when you have a child involved or a close family member involved, even with an adult, that sometimes interviewing them separately to see what they know or to assess that support could be very, very helpful. And then you have to sort of take this all in total, and there are rating scales and fancy measures. You can score things and decide if they're low, moderate, or high risk. I'm not going to get into that per se, but you can sort of talk about, what level of care is needed. And an inpatient level of care is really truly needed for someone that has acute intent and severe chances of moderate to severe worsening, that they cannot keep themselves safe, with sometimes a family support and communication. I think the other thing that's really important to understand for kids and families with suicidal thoughts is they don't just suddenly disappear. Even when kids are hospitalized or people are hospitalized, there is a chance that those suicidal thoughts will come back, even if they've been gone for a week in the hospital. There's more likely than not a chance that they can come back. So you always want to think about, well, what happens if those thoughts come back? How can we reach out? How can we let someone know that you're struggling again? What are warning signs, and how can you reach out and access resources? And so it's a conversation that is an ongoing conversation as well. And so as you think about levels of care, you think about, is this something that can be managed as an outpatient? Is this something that needs a safety plan? Is this something that can be sent home with just some resources and connection to treatment? And you want to, that's part of the giving hope process, connecting people to resources, and that idea that this can get better. You're struggling with depression, anxiety, we have treatment for that. You're struggling with bullying, we can get services in school. That connection lends hope in part of that process. And I will say that change in risk assessment can happen over the course of the discussion. You can see people that, feel incredibly hopeless, and just being able to tell their story and hear, I think you might be depressed, and what's going on at school really is something we need to get the adults involved with, because this is not okay and this is not healthy. And I believe you, and we can come together to come up with a plan and some supports for you. You can see people gain hope and trust and change their risks even in the course of that supportive interview. So this is a dynamic process. So there are some, if you've never done this before, or you'd like to get better at asking about suicidality, and I would say anyone that works with kids with mental health issues, or anyone with mental health issues, I would hope you have some comfort in just asking. But this is a free online screening questions for adults and youth. It's about 5 questions. The idea of this is it could be used actually in any healthcare setting to screen for suicidality. In fact, they are using this in WVU Hospital now for adults and kids to screen at the nursing and sort of CA level, just generally to just let people know that this is important and we're checking on this. And so there are lots of resources and toolkits online. It's called the ASQ. And I think I have it here. Oh, no, I didn't put it up there, but it is five questions. So the first part in making sure we're doing is asking. You can't just assume, and lots of people will not offer this information. In fact, some people are very secretive about this. They may have made comments on social media like our patient, but they may not immediately tell you. You have to ask, and you have to use direct language. Are you having any thoughts about killing yourself or wishing you were dead? And you have to use those words. Don't say suicide. Not everyone knows what that means. I suggest using simpler language than that. Next step is really, especially with parents, is you do have ability to really immediately help their risk. Most lethal suicide attempts in children are the result of impulsivity they reach for what they see and what is immediately accessible in their moment of distress. That's true to adults to some degree, but most suicide attempts are not weekly planned out days at a time. Some are, if there's an aspect of significant planning that actually increases their risk, but most attempts are impulsive in a moment of distress. And so making sure that there are not readily access to firearms in the home, firearms are removed, locked up, kept separate from the bullets, removed if possible, can be helpful. Also, huge risk, over-the-counter medications and prescription medications. So locking up, especially Tylenol and Benadryl and things parents don't think about, can be enormously lethal. Most deaths from overdose are from Tylenol because it is fatal on the liver. And so those two items, having parents assure there are no guns, and you have to ask the kids about the guns because the parents will tell you the kids don't know where they are. Lots of times kids know exactly where they are and they know where the key is and they know how to get it. So if you ask the child if they know about firearms in the house, or they have access to weapons, or they thought about weapons, or just asking, do you have access to guns in your house? They will tell you, sometimes not the same way their parents will tell you. So you should ask. Medicine should absolutely all be locked up. Sometimes in the emergency room setting, I will have the parents leave the emergency room and go secure the house before the child comes home, if that is all possible. If they're inpatient, that also is something ideally you should have done before they're sent home, because it is a tremendous reduction in that risk. Because if I have to pause and can't access a lethal device, I might ask for help and do something else in my plan. Listening, acknowledging, not being judgmental, and feeling again that there's hope in treatment is a huge part of that. And so even if you're anxious, if worried about what they're telling you, not running away or shutting down yourself is actually a critical part to keep the conversation going, so that they don't shut down and they know that talking is connecting, talking is help. You can help connect them to services. Maybe that's making a psychiatry follow-up. Maybe that's referring them to therapy. Maybe that's referring them to national services like the suicide prevention number. Now, although it's being outrolled in different states differently, we have the 988 line. We have mobile crisis services in West Virginia, giving them options to outreach and talk and staying connected, making sure there's a follow-up, knowing that, I'm going to see you back in a week, or we're going to touch base on how things are, will help people kind of, we talk about that standing the torch and the fuse of our tolerability for things. If we know we're going to have a touch base where someone's going to check in on us and make sure we're progressing, that lends hope, and that's a big part of it. So we would do all of these things with our patient. Couple other sort of resources. There's a text line, this is also really important, even if the suicidal thoughts have resolved. And in this case, where the report came from a social media report, where sometimes kids just say things and they say, well, I didn't even mean it. I just said it because I was frustrated in the moment. Let's talk about that. There's a good chance that thought's going to come back. So if it came back, and this is where I talk about, let's do the do-over. How would you revert, do the rewind and do it again? What could have been helpful instead of putting it on social media? Or if that thought comes back, how would you like that to be handled? I don't want to be here in the emergency room, that's for sure. Okay, well, what could we do? And then if you have a family there, mom's like, you can text me, I will drop everything. You can tell me, you need me right then, I will stop. And the kid may feel very supported by that. So it can be kind of a family type thing, because it is going to happen again, more likely. And the other thing is, I also sort of, especially if the parent knew nothing about this, and this is all new information, the parent is also incredibly anxious and overwhelmed and fearful. And so you have to acknowledge parental anxiety. And so but yet, the balance is that a lot of parents' response to this will be to smother their children with so much attention that it will also drive the child crazy. And so I make kind of a joke about that. When the parents worry, and I say, you have great family support, but it's going to be really, really tempting for your mom to never want to take your eyes off you again. And I imagine that could be stressful too. So let's talk about how we can balance that. And so I talk about setting up family check-ins. How about you guys check in every day when you get home from school? it was okay. I felt safe today, mom, no problems, just a check-in. Again, it helps build trust and capacity and communication on both ends, but it doesn't get the smothering 24/7. I told you, now I wish I didn't because you won't let me do anything kind of approach. So you have to balance that approach. And it does absolutely take time to do this. And if you can write down some of these plans, that can be really helpful as well. Here are some West Virginia specific resources. This is the Children's Crisis and Referral Line in West Virginia. They send out mobile crisis. They can link people to seaside waiver services. They actually are actually answered by a real person who can also kind of connect you to services as well, or tell you, or they can start a conversation about whether or not they would recommend you go to the emergency room or just reach out to your parents. They're actually a very good resource to know about. Okay, so we talked about in this case, and I didn't add to this case, but because there was a component of bullying in this case, I would also want to find out the extent of the bullying and if there's services at school that I could be helpful with. And bullying and the emotional distress related to bullying is a justifiable service for even a SAT or a 504 plan in the state of West Virginia, and schools do have some requirements and some encouragement to address bullying in West Virginia schools. There are ways to address the school issue. Sometimes I call the counselor at the school and let them know what's going on, or identify if it's one kid or multiple kids. Sometimes I make requests that kids change a class or just change their seating without having to make any environment. I've had kids that got bullied in the hallways, and I've asked if part of their school plan could be that they leave class 2 minutes early so they don't have to walk in the halls when other kids are there. Those can all be direct recommendations that can feel really supportive. Or sometimes you set up communication plans with school people. That can be really helpful. You have a pass. You can go to the counselor's office anytime you're feeling overwhelmed. And we can set that up for you. So there are a whole range of school services that might be available to kids. And believe me, the school wants these services in place than having to hear these things and send kids to the emergency room as well. So we can always be proactive about those things. So we also said this young lady met criteria for major depression. So we do have 2 medications that are FDA approved for pediatric depression. All SSRIs probably have some evidence for depression in some case reports, but there are 2 that have FDA approval. So I do use them first, unless there's a reason not to. Fluoxetine and escitalopram are both approved specifically for pediatric depression. The age range on the fluoxetine goes lower, so it's age 7 and up, and the Lexapro, the escitalopram, is age 12 and up. With kids, I always say you still need to get to an effective dose, but you tend to need to go slower and assess more frequently when they are. However, just because you're a little person doesn't mean you need a little dose. I think sometimes that's also something people forget. If you underdose a medicine, you get all of the side effects and none of the benefits. So it's important that you start low, but you still advance the medications to target dose ranges based on the evidence. So for an adolescent, I would typically start fluoxetine at 10 milligrams for a week to assess tolerability and side effects, but quickly bump it to 20 milligrams. 20 milligrams is the starting dose for depression. I'd give that dose about 4 weeks if they didn't have any side effects to really assess efficacy. And then I would continue to increase in 10 to 20 milligrams, reassessing each of those dose increases every 4 to 6 weeks to see how they were responding. Escitalopram, I'd do 5 milligrams per week, hold at 10 milligrams, which is the lowest treating dose for depression for adolescents, for 4 to 6 weeks. And that one can go up to 20 milligrams. This patient also had anxiety. We're going to talk about anxiety in another case. I'm going to point out that while the medicines are the same, the dose ranges are different. And you'll hear me say this again, depression symptoms tend to respond at lower doses. High levels of especially ruminative OCD, anxiety, or panic attacks may need higher doses than the doses needed for depression. So we don't have a lot of information about this patient's anxiety, but that may be something to remember as we reassess the response. In an ideal world, a patient seen back in 1 week from and reassessed with daily check-ins from the school, and we'd also probably make some referrals for anxiety and depression for psychotherapy services as well. Any questions about that case or comments about that case? All right. Oh, forgot to mention this. All of the SSRI medications, actually all antidepressants, have this warning. You've probably heard about this. This is the black box warning for suicidality. Every patient 24 and younger is deemed at risk for this. There's a lot we could talk about regarding this, but the way I present this to families is suicidality is already present in this case. In a patient with depression, if you have suicide, you're quickly moving up to moderate or to severe in your severity anyway. And so you're balancing treating the underlying condition with the side effect. I'm sure our pharmacists can weigh in a little bit. This is still quite rare. Only 2 to 4% of cases ever reported suicidal activations in some of the early studies. I think I would say it is less. Oftentimes when people have looked at time lag analysis, the suicidality is worse before the medication starts working. Sometimes energy is activated before hopefulness and mood is activated. And so there also can be side effects like akathisia or agitation from medications that can worsen the risk of suicide. And so this is a bit controversial, but the highest risk in most adolescent studies was in the first 2 weeks of that SSRI treatment, probably before the clinical benefits were really present. But it is there. I definitely have seen this worsen in kids. It does absolutely exist. I think people think it exists more than it does. Sometimes the continued suicidal ideations are just unresolved depression. In this case, as I said, the suicidal thoughts are going to come back most likely without treatment. And so you are really doing a balance of these warnings and monitoring and side effects with the risk of the underlying illness. And so that managing is really important. The check-in is really important. So I tell people, if those suicidal thoughts worsen, if you feel side effects in any way, please reach out sooner rather than later so we can talk about it. Some side effects will get better with time, some will not. Some will get better with food. Sometimes it's a quick change we can make. Sometimes we need to just stop it. And so I really want to open communication with people as we start things so that they don't feel stuck worsening with things. But that warning is there. There are some fabulous longer articles about this. I don't know if I put it in this, but there's parentsmedicationguide.org that has medication handouts for depression for parents that explain this risk and balancing the risk of suicide with depression that is an excellent read, but it's a 10-page sort of discussion. But for parents that want to learn more about it, I try to give them all that information. Okay. So this is case number 4. This patient has a history of depression, and she had done well on escitalopram, Lexapro, 10 milligrams for a few years, right? So that was our previous patient. But during the pandemic, started experiencing more OCD symptoms. This included fear of germs, contamination, getting sick, started with hand washing, was having panic attacks at the thought of being in public, and returning to school with fear of illness and getting COVID. This was a profound concern in my clinics as kids returned back from the pandemic, especially those with anxiety. While at this point, depression hadn't gotten to the level it had before, the transition from virtual school to in-person school was really escalating that anxiety and OCD specific symptoms. So what should I do? Should I increase the dose? Should I change her prescription? What would be best practice? So if patients are on a medication that has potential to treat both, I likely would start, and has had no side effects, I would likely start by increasing the Lexapro. Lexapro escitalopram is not FDA approved for OCD in children. We will talk about what those are, but certainly its mechanism of action as an SSRI, and it does have some of that indication more in the adult world. And because she has tolerated and done well on it, it is absolutely reasonable to increase that medication dose, because the higher doses do tend to target anxiety symptoms, especially panic and OCD, better than lower doses. So that is completely a reasonable step in this case. The alternative is if there were side effects to Lexapro, or maybe they hadn't done well with it, or there's something they'd tried it before and couldn't tolerate it, cross tapering to another SSRI, such as fluoxetine, sertraline might be reasonable. And when you do that, you want to set up a cross taper where one is going up and one is going down, because you don't want to rip off someone's medication and have all the symptoms flood back and that depression reemerge. So you would create a pattern for 1 week being a lower dose of Lexapro and then starting dose of fluoxetine or sertraline. Usually I would do those tapers over about a 4-week period where one's going up and one's going down. The target range for fluoxetine for OCD is between about 20 and 60 milligrams. There is some evidence you can push it above 80, but that is outside of FDA range, and you'd want to ensure tolerability. The sertraline OCD dosing range is about 50 to 150, with some evidence that you can go above 200. The average dose in terms of sort of like treatment range, fluoxetine is about 30 milligrams. And I think around some of the average dosing for OCD with sertraline is about 130-ish milligrams. So you do need, again, those higher doses in many cases to work up. So you could absolutely change. The learning point is that, and we've talked about this in other cases, FDA indication is great. And if it's there, it's helpful, use those first. There are a lot of medications that do have treatment efficacy for things, but do not have that FDA approval. And some of that, especially with generic medicines, is that no one's going after the approval, even though there is some evidence that it's helpful. In pediatrics, there are 4 medications that are approved for OCD. There are fluoxetine, which is Prozac, sertraline, which is Zoloft, fluvoxamine, which is Luvox. Those are all SSRIs. And then clomipramine is an older school medication. It's actually a tricyclic antidepressant, but it tends to be predominantly a serotonergic medicine. So it is also used for OCD treatment on label for an FDA indication. And again, those medicines that are approved for depression, again, just pointing out, even though escitalopram was not on the OCD list, there actually is some evidence for using its sister medicine, citalopram, in OCD and for depression and anxiety with kids, even though the generic does not have the indication. But again, when you're talking about SSRIs, depression symptoms tend to start getting better at lower doses of those medicines, where severe ruminative anxiety and panic may need a slightly higher dose. So be mindful of the target symptom and the dose that you're using, as well as side effects. Okay, last case. Actually, I think I have 2 more cases. This is a complicated case. This was a child that had been adopted. He had a lot of medical issues. He had a history of DiGeorge syndrome, which is a genetic syndrome that causes midline abnormalities, sometimes within the heart and the palate, had mild cerebral palsy, and had a history of anxiety and depression, had been on the wait list for mental health services. And because of that anxiety and depression, had been given Prozac, but started presenting at 10 with auditory and visual hallucinations that were very profound about the devil and the demon, telling him to kill himself. These were not trauma-related symptoms by any means. He was believing them, started exhibiting bizarre behaviors, started having this abrupt change in what the family was seeing. He became almost paranoid, suspicious, was running away, made threats to jump off the bridge. The pediatrician who had seen this kid their whole life just called me and was like, he's so suspicious. I don't even recognize this child. I've known this child for so long. This is so odd. This is so different. I mean, he doesn't even make sense sometimes when I talk to him. I have no idea what's going on. They'd sent him to the emergency room once because he made some suicidal statements. But the follow-up from the emergency room was with the pediatrician, and she's like, I have no idea what's going on. There was a family history of some autism, but there wasn't any history of trauma. We didn't know much about other family history, but this key abrupt, severe change in how this child was thinking and presenting was very, very concerning. And so this was one of the few I said, this child absolutely needs a child and adolescent psychiatrist. You're describing psychotic behavior that sounds real, legitimate, and a clear change in proposition. I also had worried with the activation that perhaps the Prozac was worsening, and having clear, fearful paranoia and suspicion that was not related to trauma is really, really key. So we started some Risperdal, and I had the pediatrician get the fasting labs for that, walk them through how to fill out the authorization paperwork. And then this was a huge learning point in this case. And this is why kids always have to be reassessed. This child had DeGeorge's syndrome, which is a 22q11 deletion. It has a severe risk of lifetime psychosis. About 1 in 4 patients that have this genetic syndrome will actually develop a psychotic disorder. And so that behavior marked with this elevated risk really was a very strong concern for the development of psychotic disorder. And they do tend to present earlier than you would see. And so I actually saw this kid in clinic about 2 weeks after the pediatrician was able to start the Risperdal. Did a lot of psychoeducation with the parent about that risk. They had no idea about the DeGeorge's risk, which is something, to remember, to warn people about with kids and monitoring. And this child was getting better. The voices were decreasing in intensity. The child didn't appear as paranoid. He wasn't running away from home, and he was looking more like his baseline. And so we bumped the Risperdal up to full 1 milligram dose, and the child did improve. So it is important to note that true psychosis is incredibly rare in a 10-year-old, or even before puberty in most cases. Most of the time when kids are talking about hallucinations before puberty, it's likely developmental, imagination, or much highly associated with anxiety and trauma disorders or magical thinking than true psychosis. But this patient had an abrupt, severe change in his baseline behavior that and a specific genetic risk, and really was presenting with psychosis. The other thing I think that was clear is people got so focused on his suicidality because the voices were telling him to kill themselves, they almost missed the thought disorder. And not all suicidal ideations are from mood disorder or depression. And I think that is incredibly true. In fact, in children, does anybody know on this call, what is the #1 diagnosis associated with suicide risk in kids? Anybody know? It's not depression or anxiety. It's actually ADHD. People do not think that, but the impulsivity of untreated ADHD actually increases the risk of suicide by numbers in kids that have mood dysregulation. Because if you have dysregulated motor movements, you also have dysregulated emotional impulsivity as well. And so actually ADHD is more likely in kids with suicidal thoughts than even depression. But in this case, they couldn't get past the suicidality to see the psychosis. So it's important to remember. This unusual behavior was paranoia. And that statement, when people say, I don't recognize this child, they are grossly different than I have ever seen them before, we really ought to stop, take pause, and assess what is going on. That is often where severe psychopathology or intoxication, dementia, or SPMI level type psychotic mania behaviors really do emerge, and we need to pause and take that at its risk. And also, I don't usually tell pediatricians to start Risperdal, so that was an unusual thing for me, but this pediatrician was invested and was doing the right thing, and so I think it's also important to utilize your referral sources, because of all the kids that get sent from an emergency room to follow up with a pediatrician for depression, anxiety, and simpler things, this is probably a kid that needed the direct referral to psychiatry. All right, last case. This is a 9-year-old with a history of autism. He had previously had a verified ADOS with past formal psychological testing. He had sensory delays, language issues, had an IEP at school, and had a self-contained autism classroom, and was seeing occupational and speech therapy. He had referrals to ABA therapy. But the problem was he was so aggressive with his providers, he wasn't getting any of his services. So he was biting people, throwing fits, who made no progress in speech or occupational therapy or ABA because he wasn't able to participate because the aggression was so bad. And the parents were reporting severe daily tantrums up to an hour at a time, would hit himself, scratch himself, had severe skin abrasions, would bang his head, throw items, really could not at all be settled. Lots of issues with transitions and change that were really escalating the aggression. So while there are no medications that will directly treat core symptoms of autism or the social reciprocity defects, addressing aggression in children with autism with medications may be important if they cannot work with their therapist at all the psychosocial interventions. So I know I have the whole PBS team on here that works with these kids every day, but if you cannot work with these kids because they are so unsafe, that may really truly be a reason they need a medication referral, because there are medicines specifically indicated for that. These medicines can be life-saving to these children to just be safe and be able to then get those services going. And so these two medications, risperidone and aripiprazole, are approved specifically for severe irritability, severe tantrum, self-injury, and physical aggression in autism. This is not just talking back or being mildly irritable or annoyed. This is that functional impairment from how bad their symptoms are. And so these are powerful medications. People are fearful of starting them. They do require prior authorizations and many steps. But if you do see a child like this with all the services in the world in place, but they can't participate in them, medication is definitely indicated. After you get lab work, vital signs, make sure they don't have movement abnormalities. Starting either one of them is quite reasonable. Traditionally, I pick Risperdal first over Abilify. It has substantially more evidence base and a longer history and is mildly sedating, that I usually choose it first. I pick aripiprazole in kids that may already have a metabolic condition or be overweight because it does carry a little less risk of weight gain. But the aripiprazole is a medication that is a partial agonist as opposed to a full agonist at the dopamine receptor. And so there's a little bit higher risk of akathisia when you start Abilify until you get it up to a certain dose that you have to work through. So if you have someone that's going to get worse and the parents can't handle that, I usually pick the Risperidone. But either one of them absolutely have evidence. I start the Risperdal at 0.2 milligrams twice a day, usually for 1 to 2 weeks. And this is a really important part. You have to know the frequency and the duration of the tantrums before you start them, because they will not completely go away. It's really important that you don't tell parents this is a miracle drug. They are not going to immediately have a child that stops having a tantrum the next day. They will see a decrease in frequency and intensity. And so if a parent comes back saying the tantrums only last 10 minutes and happen 3 times a week, that is an absolute success. And most parents will agree with that. It's important that absence of the symptoms are not the target or you will fail. Most of these medications are approved because they have about a 50% reduction, not 100% reduction. So you want to make sure you track that as well. And the goal is functional improvement. So to get to the tolerability to get into all the other treatments, to start participating in speech, because some of that aggression is related to not being able to communicate, or maybe sensory issues or other things. The medicine cannot completely and utterly help all of the factors that might be contributing, but the goal should be to re-engage in the services. The average dose for Risperdal, you can definitely see success at the 0.25 range, but certainly going to 1 to 2 milligrams a day is not unreasonable, especially if there are no side effects. I would be mindful of that. I've pushed it up to about 4 milligrams. Once you get above 4 milligrams, you aren't getting anything, you're getting side effects, I would reassess. But again, go slow. You can increase at a rate of about 0.25 to 0.5 a week, making sure they're not stiff, making sure they're not sedated, making sure they're not akathetic. But this is completely and utterly life-saving for many kids to get the services they need. Again, just some West Virginia resources, again, the helpline. And these are the regional mobile crisis services and teams. This can also be accessed directly or through that 1-800 number. There's a children's mental health wraparound project that with PBS often helps bridge people to they can get to higher levels of care, such as a children with SED waivers. Didn't put it on here, but there's also an IDDD waiver for kids. And we talk about sort of collaborative care options. This ECHO is certainly one of those things where we can share and discuss from a lot of cases, but WVU also has a MARS line that can access a psychiatrist for physician-to-physician services if there are questions about medicines. All right, any questions?
Thank you so much, Dr. Swagger, and thank you for those resources at the end. And I'll be sure to attach your PowerPoint in the recap email. We did get a question from Teresa. She had asked, are professional school counselors properly trained to engage in those risk assessment questions before sending a student to the ER? And then she said, as a former teacher, we're generally terrified of having a student express suicidal ideation to us. While I understand the need for the assessment, if something could possibly go wrong, there are so many repercussions, both personally and professionally. So Teresa, if you have anything you'd like to expand on that, you're welcome to unmute as well, but I thought I'd read that out loud.
That's a really important question. So a lot of it depends on who the school counselor is and what their training is. And you guys probably know this better than I do, but not all school counselors are not mental health professionals. Actually, the original school counseling degree was an academic guidance degree. And so while that has evolved to actually having trained therapists, a lot of times the counselors are not mental health trained. Some are not. And so you have to be clear, is this an administrator that has worked on academic counseling, and services, or is this someone with mental health training? I think they have merged more toward that in the last 10 years, but many of them have zero training if they've been around a long time, because that was not the initial need of a school counselor. That is a true need that has emerged clearly in the last 2 decades. And yes, there is a huge movement to build school-based mental health services for this exact reason and truly train people. And absolutely, you need training, but training does not help you get over your own anxiety about this, because this is a huge fear-based thing, right? Like, you don't want to screw up. And what I tell people is you will do better listening and being kind and not giving any advice by just listening at first and then connecting. And so anyone, friend, family member, can pause and encourage the expression and connect, even if they have no idea, even if they themselves can't do the risk assessment. So with kids, I do think it would be far better to talk to the child and pull in their parents and assess that relationship than to, I think actually the worst thing, and this causes way more problems than you probably realize. Lots of schools will bypass the parents, put the kid in the ambulance and send them to the ED. I've had schools do that. That is a disaster. The kid is angry, the parent is angry. It shuts kids down. They don't even want to talk about anything. You can't figure out what's going on. The parents are screaming at the school. It is really a disaster. And so the most we can do to communicate and be kind and supportive. And I kind of am like this trauma-informed person. I think every member of every team should have some knowledge of how to do this, because it is so common. I don't think that schools will ever be comfortable making the decision about the risk assessment, and that's okay. I'm not asking them to do the risk assessment. I'm asking them to start the conversation. Ultimately, there's lots of different ways to treat this. You do not want to be antagonistic about it. And it is very antagonistic to have I'll get kids in the ED that clearly don't need hospitalized, that weren't even suicidal. They have a great explanation for what happened, and the school won't even let them back without a note. And it's not helpful. It's not team oriented. And so I agree that it's complicated and scary. And I don't think many people, until they've practiced a lot with support are going to feel comfortable issuing a level of care assessment. But it really is hopeful that we can all start the discussion, because even like domestic violence screenings, being able to have multiple people help you and support and know it's along the way actually builds the chance that people will tell you the truth, and people will lie. That's the other part about this. People will not tell you things because they know what you're going to do. And that's actually the worst place to be, because then you can't be helpful. And so you want to give every opportunity for people to tell you what's going on, offer help, not control. Control and threats are not the way to address suicidal ideations. And it is a balancing some of our own anxiety and an unsafe situation. And it's hard. I mean, it's really a hard balance. And I will tell you, every case is different. So it's really important to just be individualized and meet people where they are. I wish it was more simple than that, but I think everyone should know how to ask about those thoughts and have some semblance of a plan. And of course, if you're part of a school or you're part of you always want to think about the system before you need it, right? Like, if this child shows up in my clinic and they're suicidal, or what is our school policy for managing suicidal kids, and does it make sense, and is it supportive? And, setting up those systems is really important, because this happens every single minute, honestly. So, I wish I had a better answer for you. It's not easy, but I hope this helped a little bit.
Thank you, Dr. Swagger. Yeah, no, it's certainly a complex situation and topic without a clear answer. So thank you so much. Teresa, did you have anything else you wanted to ask as like a follow-up? I saw you chatted in saying yes, thank you. But you're welcome to follow up. Everyone's welcome to ask a question. Any other comments from the group, or maybe some scenarios that you've seen and would like to bring up with the group? Alrighty, well, if there are any follow-up questions or comments afterwards, you're welcome to email them to me and I'll make sure to have them addressed. Thank you so much, Dr. Swagger, for completing part 2 of this presentation slash the case presentation. So interesting, and really does spark some great food for thought and discussion. So thank you so much. The only announcement that I have is that the next session will be on July 5th. And Dr. Swagger, we have you down for that day as well, presenting on in utero substance exposure and impact. So we're looking forward to that. I don't think we've had that topic yet so far. So really looking forward to that. And then I guess I can quickly launch a poll if you all don't mind. It shouldn't take more than a few minutes, but if you don't mind sticking around for that, it really helps us kind of get feedback to improve the session. So you can fill that out. Once you do so, you're welcome to log off, but I hope you all have a wonderful rest of your afternoon. Thank you.